All right. Good morning, y'all.
Good morning.
It's good to see both of you. So my name is Allison Puente. I am the current president of the LSRT. I am the assistant professor, one of the assistant professors at McNeese State University in Lake Charles, Louisiana. I actually live in Texas, but my entire professional life has been devoted to the state of Louisiana. So I claim both states. And I'm blessed to work with Sarah. So Sarah, I'll let you introduce yourself before we introduce our guest.
I am Sarah Barnes. I am the president-elect right now for LSRT. I am an educator in Alexandria, Louisiana at Northwestern State University, and born and raised in Louisiana. So definitely an advocate for our profession and just want to, again, just be proactive instead of reactive. So
And I am Jennifer Thompson. I am the current president of the Tennessee Society of Radiologic Technologists. I am a full professor and program director of a radiography program in Austin Peay in Clarksville, Tennessee. I do have to make a disclaimer. I am a governor-appointed board member of the Tennessee Radiologic Imaging and Radiation Therapy Board. So the things that we talk about today are not the opinions of that board, but I just wanted to just clear up to say, yes, I'm part of those, the board members that do make the rulemaking for licensure in Tennessee.
I'm so glad you said that because I didn't know that about you. And that brings up a whole other topic we can discuss in a minute because Louisiana has challenges related to separating the society from the licensure board as well. And I'm curious to see if Tennessee struggles with that at all.
Well, I guess I can just answer that so you don't lose the train of thought. So in our meetings, we've actually been asked, hey, where is your TSRT member? Where is a representative? Can we add them to the board? So we do have support of stakeholders being representatives on the board.
That's good. I think that's important. Louisiana has that as well. The frustrating thing in my perspective as an LSRT member and advocate for the society is that our licensure board acronym is very similar to the affiliates acronym. So the affiliate is LSRT. The licensure board is LSRTBE. So it's Louisiana State Radiologic Technologists Board of Examiners. So, and I can say this in full confidence because I was as guilty of it before I knew the difference. But a lot of our techs just don't understand the difference between paying a membership due to the affiliate and paying renewal fees for your state licensure. Or they'll assume because they're renewing their license that they're also a member of the affiliate society, and they're not. And so we do encourage their membership to the society so we can have that support, which is why Sarah and I would love to speak with you today about why it's important to be an affiliate member. But that is something that challenges us in getting additional members because there is constant confusion there. So, all right. Well, the first thing I would like to do is just thank you for coming on to speak with us today. As Sarah and I had discussed wanting to talk to you and wanting to share our discussion with you to the state society members and even those who aren't members, because this is going to go out on our Facebook page, which is a public page open to anybody that likes that page. But I guess about a month ago, maybe, and correct me on the timing, but you made a post on the ASRT communities page, just introducing yourself and the challenges that you are currently facing in Tennessee. Would you just kind of share with everybody what that post stated?
Right. So in January 31st, 2023, a new bill, or they call it an act, was introduced in the state Senate and in the House that will remove the Radiologic Imaging and Radiation Therapy Board. All oversight of radiologic technologists in Tennessee will be overseen by the Division of Health. We do not know who these members will be that will oversee the technologists, but it will definitely not be technologists having oversight of technologists. Currently, limited scope technologists and those that are working in physicians' offices do have to be licensed. And this is under an old statute before 2016. And under that statute, it gives what a limited scope is allowed to do. And then in 2016, we had legislation passed to create the Radiologic Imaging and Radiation Therapy Board to create rules for all radiologic technologists, including limited scope. Those rules were accepted and went through all the different committee levels in Tennessee, and we were going to have those completely implemented in June of 2022. However, in May, a pretty good lobby group contacted the board staff and said that it's not right for us to have licensure for all technologists and that people are going to lose their jobs because of licensure, and we need to take away the rules. So we want to listen to our stakeholders. So we did drop those rules so that we could have communication with that stakeholder and have a communication to know that, what are we really doing with jobs in Tennessee if this licensure bill or the licensure rules get established. And so we dropped the rules, and in October of 2022, we had a meeting and we established its task force. That task force was 3 different technologists from the radiology board, and then also 2 stakeholders. So 1 person from the rural community and another from the Tennessee Hospital Association. We agreed on rules, and those rules would be that all technologists should be licensed, limited scope would be licensed. We would keep the same rules with limited scope, so without them being able to do CT or fluoro, portable, MRI, any of those advanced modalities because they're not trained to do so. And so that we would not eliminate jobs, we included an exemption. So 1 year after the rules are established, any technologist working in CT, MRI, they would be able to file an exemption so they could keep their job. If you didn't file an exemption, you would have 2 years to do training to get your ART certification. So those rules were all agreed upon in January, I think it was the 17th, 2023. And then January 31st comes this new bill by Senator Crow and House Representative Reagan, eliminating the rules for limited scope. So limited scope rules under the new bill, they would be able to X-ray the certain body parts. However, it takes away the limitation of fluoro, CT, advanced modalities. And it also adds that the state of Tennessee will certify technologists not licensed. We are confused about that, or I'm confused about that language. But one of the major things that it does is it does take away oversight of technologists by technologists, and it eliminates the rules for limited scope to work in advanced modalities.
Wow.
Okay. There's a lot there. Okay, the first thing that made me kind of raise my eyebrows, so that board was established in 2016, you said?
Yes.
Okay, so it's a pretty recent development in of itself.
Mhm.
Okay, so prior to 2016, who licensed technologists within the state of Tennessee?
The Medical Board of Examiners. So anyone working in a physician's office would need to have a license. So those that are working in hospitals do not have licensure.
Okay.
Oh,
Now, did you find prior to 2016 that most hospitals were still asking for technologists that applied to be ARRT certified, or were they truly hiring whomever?
I think hospitals want to maintain that quality of care. So I never heard of limited scope or non-ART registered um, professionals doing x-rays in hospitals. But this year really opened up what's happening in Tennessee, where limited scope technologists did come to the meeting saying that they are working in hospitals, that they are currently doing advanced imaging, beyond, and that's really against the law for the statute. So we wanted to think that all hospitals were abiding by, let's just only allow full scope ART registered technologists to work in hospitals, but that just isn't the case.
so were they advocating for them to stay as limited licensure techs, or were they wanting to go back to school to get the full scope?
Yeah, so that's the big problem that we have here. So um, specifically the Tennessee Health Hospital Association, they do represent rural communities. Tennessee has lots of rural communities, really everywhere in the South has rural communities. So this is why a lot of this will affect different states if this passes. So what the Tennessee Health Association is saying is that if we implement licensure and limited scope technologists are not allowed to do CT and MRI, they're not going to have anyone to staff the hospital. Now, unfortunately, they are supporting going against the law as it is now, because limited scope cannot do advanced imaging. So I'm not sure why they think that they can. So in essence, what's going on is that our rural communities in Tennessee have unequitable care. They could right now be imaged by those that are not registered under full scope of practice. And with the new act, that'll definitely be the case, that limited licensure will be able to work in hospitals and do advanced imaging, and that quality of care will not be accessible in rural communities.
I love that you keep supporting it too with equitable care, because it's not about putting my job at risk or putting your job at risk. We're talking about ionizing radiation being dispensed in the hospital setting by professionals or personnel that are not educated,
Mhm.
to do so.
So I think from being on the board, I've been on the advocacy committees for ASRT, and I'm on the Tennessee board, and it's really changed my viewpoint about what advocacy is. We always talk about advocacy with encroachment. We don't want others, coming into our field, doing our jobs, but really it's about patient safety and quality of care. We're responsible for our patients and for them receiving no harm, and that harm is ionizing radiation that you can't take back. It's cumulative. So if someone doesn't know what they're doing and they are imaged twice because they they didn't know what they were doing, or that quality of image wasn't to par as what an ART full scope technologist would do. That patient has increased harm biologically. And then also just by personal experiences, and I know that I kind of am preaching to the choir, because I saw on your on the Louisiana page that you guys do not support limited licensure. So I have worked with limited scope, and I quickly said, you maybe go do those blood pressure checks, because they could not do the imaging, and especially at the quality that a full scope technologist could do. And at one of the locations that I would work at, this was back in film, I'd pull the films for the radiologist, and the previous films were just not diagnostic. Mm-hmm. And the films that the full scope technologists were doing were diagnostic. So not only do we have unequitable care in rural communities, but maybe those in those communities aren't even going to have diagnostic imaging being done, or diagnostic images being provided to radiologists. So we might be in a case where Tennessee, one, we are increasing misdiagnosing, and two, increasing malpractice, which costs the state millions of dollars.
So that immediately, what'd you say, Sarah?
Increasing the patients coming back, because the doctor is like, well, I can't see that, so in the image that they provided, so now I need you to come back to get another image. But then what if it's by the same tech and they didn't see anything wrong with that image because they didn't know what to look for? Mm-hmm. So I wonder if they even have like the doctors talking and saying, okay, well, this is wrong with this image, even if it's something simple, can you lighten it up, or can you make it darker, or the centering is off? Like, will they be able to know how to critique that image in order to make it better the next time?
Yeah, it just makes me wonder where the radiologists are. I mean, I know they're more passive now than they were, 20 years ago. We talk about that all the time, even in Southwest Louisiana. But it seems to me like the radiologists would really have input here with the Tennessee Medical Board.
So they do support revoking this bill. So we have received, the ASRT has received some communication that the Tennessee Radiologists Association will reject this bill.
So is a problem coming? I don't know how many schools are in Tennessee, but is it not enough techs being like student to techs? Is it not enough coming out of school, or I mean, what's?
I think that we are producing enough technologists. I just don't think that they're in the rural communities. And let's face it, hospitals are about money. And if they can pay a limited scope to come into their hospital and not pay what a full scope is being paid, that's what they're going to choose. And also, if you are living in a rural community, and if you can drive an hour down the road and get paid twice as much, that's what's going to happen.
Yeah, it all comes down to money.
Mm-hmm. Right. And, really, if we could get a push from insurance companies, especially Medicare and Medicaid, if they pushed for full scope licensure within all modalities, this just wouldn't be a conversation that we would have to have.
Yeah, that would be a glorious day.
I didn't even think about it from that standpoint, because like they're pushing now that you have to take images and they have to be digital, they're even pushing away from CR. So, but that is a good point.
And, and boy, the move from film to CR to digital, that's also another threat with our patients, with those that aren't full scope, because we know that limited scope, they don't understand how to change an image. And now we're going to have increased dose creep, which increases, that patient harm. So yeah, digital is great, but I think it does open the door for more unqualified individuals doing imaging in our hospitals.
Yeah, it really is like the perfect storm of what you're experiencing in the increase in limited technologists, the now more accessible imaging in every doctor's office, urgent care, hospital. Imaging is just on the rise because it's more accessible, it's more affordable. Reimbursement rates are higher. And then you complicate that now with just the increase in imaging overall and how physicians are ordering more imaging to support their diagnosis. It's like the worst case scenario of all elements combined. And it really is so achievable. The answer is easy if we sit back and just plan it out all on paper. But getting there takes decades, and it takes so much work because it doesn't always end up in the most financially responsible answer, but really what we're advocating is patient care. And unfortunately, what motivates a lot of these decisions is money.
And I think one thing, I think on a government level, I just don't think, well, I know that they don't know what a radiologic technologist is. I really think that they think that we're all radiographers and we just press a button, we get an image, we send it off, and then someone else reads it. But radiologic technologists are nuclear medicine technologists, they are radiation therapists, CT technologists, MRI technologists. I just don't think that they understand the scope that's underneath the umbrella of radiologic technologists. And I think if they understood what the practice standards for ASRT, if they were just given that list, I think it would just open up their eyes and go, wow, if we are licensing nursing, we've got a licensed radiologic technologist. They are doing IVs. They are compounding radioactive radiopharmaceuticals. They're doing incredible things in hospitals, but that's not what the lawmakers see. They just see the button and then a picture.
Yeah, you're so right. So I wasn't even going to bring this up, but you have reminded me of it. So the current president of ASRT, that's his big presidential initiative. And I'm so excited to see that. His most recent update, I think, is that they're going to kind of share what press firm that they've gone with and what updates we're going to see in terms of, like, I don't know, television ads or something. I don't really know what they have planned, but I know he's doing a lot to advocate for the profession as a whole and how we contribute to the healthcare team in our role. So I'm excited for that. I think his biggest update maybe is going to come at the House of Delegates this summer, but I hope that the timing of that is important for you because, it can help educate a lot of those legislators about the importance of full licensure. So I wasn't even going to talk about this, but just in full transparency, honestly, Louisiana has always been a full licensure state. We have not had limited licensure. So I knew that limited licensure existed in neighboring states. Texas has limited licensure. So we know that it's out there and we know that it, has worked for years, but I'm a little naive, I guess, in what it looks like. I have no idea because I have never worked with a technologist that had limited licensure. So can you just talk a little bit about that, about what you know? Where are they getting, what are the education requirements at all? And where are they getting their limited licensure certification?
So we do know that there are some schools that offer limited scope. Full transparency, we myself and I think as a board we've had a hard time wrapping our minds around limited scope. So sometimes at the meetings there is someone that is an educator with limited scope that reminds us of some things that that we don't really know about. But the curriculum, if you go to ART, the curriculum looks very similar as full scope, but they do not, they're going to a weekend course to learn different parts of the body. So they'll go for a weekend to learn a chest, and then go for a weekend to learn extremities. Now, I say a weekend, but I don't 100% know how long these courses are. They're definitely not 2 years and thousands of hours of practice. That's for sure. But they are limited and they take an exam per body part. So if they are going to do skull imaging, that would be a separate ART exam. If they did chest, that would be another exam. They don't have abdomen in their scope of practice. So really they're meant for that doctor's office that receives just a few, x-rays a day. Maybe they're at a podiatrist's office and they specialize in feet, or they are at a chiropractic office and they specialize in spine. That's really what it was meant for. It's not meant for
CT.
CT, because even in the statute it says they do not have the training and the competency to know how to do CT. And in most of our programs, our students spend 2 years. I mean, they have prerequisites, but then they have 2 years of nothing but really radiography. They're not even ready to do CT at the end of the day. They 100% can't do MRI. That's an absolutely different scope of practice, a different set of physics. It's just insane to me that you could go to school for a weekend, not know any of the things, any of the principles behind the machine, and then be able to go do advanced modalities. The argument is, well, they're just training on site. They are being taught how to do MRI and CT. But if the scope of practice limits them from being able to do those modalities, it's unethical for any ART full scope technologist to even train them.
That's such an important thing because that puts your own license at risk, and people don't recognize that. Every now and then in the communities page, you'll see something pop up about, I've been asked to do this. What does that do to me? How does that put me at risk? Those questions are so important because you need to know what puts your license at risk.
Exactly.
And it's not, it's not someone being insubordinate. It's you advocating for your own profession and for patient safety when you bring up those questions. I think some people are, just feel fearful in asking those questions sometimes because they don't want to seem, abstinent. But
I mean, if it's unethical, it's unethical. Whenever I teach ethics, I always say, like, whenever you graduate and you pass your registry, pass the certification exam. Pass the certification exam. That is your baby. That is that's yours. You don't want anything to jeopardize it. So sometimes you do have to question it, because it is unethical and you just don't want that. So my question for you, Jennifer, is as far as affiliates, what can we start doing? What do we need to, what should our push be? Have y'all seen an increase in members because of all of this happening?
I don't think technologists understand what's happening. So for the affiliate, I think their job is to educate. So I think a few things that are really important for our technologists to understand. The first is licensure is not a money-making scheme. We know that technologists are paying ART, they're paying ASRT, they're paying their affiliate fees, and now they don't want to pay this licensure fee. But in the state of Tennessee, a board cannot make money off of their fees. And so if you are over X number of dollars, you've got to figure out how to liquidate those funds. And so it's not about making money, it's about paying for the staff to issue those licenses. And then also educate that, you know, licensure does keep our profession safe from other people encroaching on doing imaging and therapy. And I don't know about Louisiana, but right now we are celebrating in salary. You know, we are seeing bonuses for the first time. The hourly rate is just something I never thought that I would ever see. And if technologists don't support licensure, they're losing money. So that $100 a year, $50 a year is going to be nothing compared to the salary that they're going to lose if they're able to hire people at a lower cost because they're allowing those that are not full scope to practice. The other thing is to know who are your allies. So who are those lobbyists that will lobby for you, and know who your, I don't want to say enemies, but enemies. Who are the enemies against licensure? Who do you know has had a history in not supporting licensure? Definitely don't talk to them. Don't let them know what's going on, because they can have a very powerful voice in lobbying to senators and representatives. So, you know, if you guys are feeling confident in licensure, I wouldn't make it a big deal that it could be taken away, because that's just giving an idea to someone else that, hey, licensure doesn't have to be a thing in our state. The other thing is to make sure that someone in your affiliate, someone in your hospital, someone in your educational institution is going to your board meetings. You need to know what's happening with rules, how rules are changing. You know, there's a set of people that are on this board that are making decisions for your profession. You need to be there to speak up for yourself. The other thing is for you to have a legislative watchdog. I can't tell you how many technologists, how many hospitals said, oh, I had no idea that licensure was coming. Really? You spend a lot of money in government relations, but you had no idea that this licensure was coming. And it's really easy to follow the Senate and the House's weekly meetings. I'm sure that Louisiana has the same thing, where they could be emailed to you every week. Know what's on the docket so that you can see what's being proposed, you know, and if you have something that's proposed, it doesn't mean it's the rule. You can be active against those bills when they come. You just don't want to be on the other end of it whenever they get passed because you just didn't know it. So each and every one of us as technologists have a responsibility to the profession. You need to be educated. You need to know what's going on. If you didn't know what's going on, then you can only blame yourself later when your salary gets dropped, or you're having to train a limited scope to do CT. So we're all responsible for what happens in our profession.
Yeah, I think a lot of what you hear sometimes, because the world of radiography tends to be so divided into, you know, subgroups. So the MRI techs may or may not be concerned about limited licensure because it affects them less than, you know, a diagnostic radiographer, or someone in ultrasound, you know, isn't paying attention to the conversation because it doesn't affect them in the same way, or so they think. But it does. It does. Everybody at the end of the day is going to be affected if the licensure is opened. And what I really envy about nurses is that it doesn't matter if you're an ER nurse or a cath lab nurse or a nurse at a doctor's office. When the nursing law is challenged, all nurses speak up and they rally together. And I wish we saw more of that in medical imaging. And I hope that improves. But you're doing a good job of explaining of how it affects everybody, especially in your explanation that limited licensure, those technologists in the state of Tennessee are performing those advanced modalities. This is not an isolated issue. This affects everybody who is performing medical imaging, regardless of what post-primary modality they're in.
Yeah, I'm glad that you mentioned the culture of nursing, because they are those that just stick together no matter what happens.
Mm-hmm.
I'm in Tennessee. The big headline about the nurse at Vanderbilt, probably. So this is the story. So so at Vanderbilt, there was a nurse that gave a patient the wrong medication. She was supposed to get sedated for, I believe it's for nuclear medicine scan, and that nurse gave the wrong medication. Nurses rallied around her, although she made a critical error, and she was put on trial for murder. And here's kind of the thing that gets to me. So the nurse actually gave the medication in the nuclear medicine suite.
Mm-hmm.
The nuclear medicine technologist was next to the IV, and the technologist asked if the nurse wanted him to push the medication. Would this have been a completely different story if that nuclear medicine technologist pushed that medication and killed that patient?
Oh, 100%. Yeah.
Yeah, but that's
And
even still, don't stay. I always tell my students, stay in your lane. Like, don't even ask that. Like, you shouldn't even, that's not you. That's not an isotope. Leave that alone.
right. But within our scope,
Mhm.
especially in Tennessee, there's nothing that says that we can't push a medication.
Right.
And so would technologists rallied around this nuclear medicine technologist if he would have pushed that medicine? I just don't think that we would have the same response as nursing. And but maybe we wouldn't have this licensure battle. I'm not really sure. But I think that lawmakers need to know that radiologic technology is dangerous. It can, depending on what we do, can be life-threatening. In radiation therapy, radiation burns are normal. We are burning through normal tissues, causing patients to get sick, and that's just normal within the scope. It's normal within the practice. And so if you have a radiation therapy person, I don't want to say technologists, if they are just trained on the job, how are they going to know that the machine is calibrated correctly? How do they understand that those simulations have to match the treatment? I think if you're going through a 1 year to 2 year program, you're being preached that every day. But if you just go on a weekend and get trained, that's just not something that's indoctrinated in you to keep that patient safe. So it's not just radiography. It's worrisome that it's broader than radiography. It's all the modalities that are actually at risk.
I think also adding on to that, just think of whenever like somebody that went to CT, like they went to the structured education and different things like that. And then they cross-train somebody that didn't do that. So they're just going to teach them the fundamentals, right? But then it gets to that limited scope tech, then they're just really learning the fundamentals because they don't know. So it's just a trickle down, like, why did you do that? I don't know. That's the way I was taught. No one could even explain, like even the person that, so the things are going to be a loss along the way. So that's something else to think about too.
Right. And, and I was going to be trained in CT. And so I'm full scope. I was going to be trained by someone in full scope. And I went and I was doing CTs and it was so much fun. But when I would ask the why, this technologist would say, if it blinks, push it. And I needed background. I need to know the why. I need to know, why am I giving contrast at this time? Not just because something's blinking at me. And if a limited scope technologist doesn't understand the physics behind things,
Right.
that's how your full scope tech is going to teach. And so there's just not going to be really continuity of care between a full scope and a limited scope. There's just so many dangerous factors that are going to come into play if we're able to just open up the doors to anyone being able to do imaging.
So that brings up to me, Allison. It's like I want this video to go, but then I'm scared because then what if they start looking? Oh, well, let's look at that licensure.
Well, you said it earlier, Sarah. I mean, Louisiana is currently blessed in that we are a full licensure state, but the threat is on board. I mean, from everything that I have heard from like very valid sources, licensure is being challenged in the state of Louisiana because there are large hospital corporations that cannot staff their departments. And they feel like they can staff those departments more efficiently if we had limited scope of practice. Now, that limited scope, I have to assume, would still be licensed by the LSRTBE. It's not quite the same as what you're saying is happening in Tennessee. But I don't know. I haven't read that. I just am assuming that. I have no idea.
And we don't know if it's going to be just the single, like a foot or a chest, or is it going to be like they're removing it and this person can eventually go off the CT and MRI, and like what's going to be the thing? Like I would feel like, man, I did all of this work and here this person come in just be boppity, and doing the same thing that I'm doing.
Yeah, again, it's not even about like my job protection. I mean, I'm a teacher now, so my job is safe. This is not even about like the protection of my role. This is about having someone sitting at the CT scanner that has some idea of how pitch and scan time are affecting dose and image quality. So, and you can't just help everybody understand that when they're getting on the job training, because most of the time what you see there, even for certified CT techs, sometimes if they took that CT certification in 2006, guess what? They probably cannot explain to you, the difference in pitch sometimes, honestly. So especially when you get to those rural areas where you have that on the job training for 2 weeks, and then now you're working your shift by yourself. So when it gets to a point where you're not getting the bolus on a PE study, you don't have the opportunity to look at your coworker and say, hey, help me figure out what I'm doing wrong. That tech is going to sit there and repeat that scan, until they get an image that they feel they can send to the radiologist. And what happens to all the scans that were undiagnostic? They get dumped. Nobody ever knows they even existed. Nobody knows the patient got 8 scans that night. Nobody, because there's no QC tech that's looking at the scanner. It all goes underreported. That's the importance to me, is what is happening to our patient exposures. Because as imaging is increasing, we have to have more protection and more knowledge in how we're performing not just the scans, but the x-rays as well. I see it all the time. A patient comes in and maybe they're doing 4 odontoids before they get the one that they can send. I know that dose is minimal. I know. We're talking about a decimal of a microgray. I get it. but it's cumulative. And how many C-spines is that patient having? And after they have that C-spine, now they're going to go have a CT of the C-spine. You know, it never ends. So if we don't address it now, then in 10 years, the three of us are going to be sitting here having the same conversation about, gosh, you remember the days when we had a hold on what we were doing and patients could go confidently get a C-spine x-ray and not have 15 views.
Right.
So,
Well,
you know, and I know I'm preaching to the choir, but there's such an urgency in me. If the technologists in our states do not understand what is happening, where are we going to be in 15 years from now? It's going to be a different conversation.
well, I think you have to also add adding patient knowledge. So if your technologists aren't going to be your voice, your patients have to be the voice.
Yeah.
You know, they have to be contacting. You know, if it's a threat, they need to know who to contact to say, hey, you know, I know when I walk into a hospital, everyone's a nurse. I have no idea what the scope of practice of anyone that walks in that's treating me. Half the time they don't even introduce themselves to me, and I don't know what their role is. And if I'm in a CT scanner, I don't know how many times they've pressed that button. I don't know if they never say, oh, we've got to repeat this because I didn't do a good job. They just say, oh, we got to do a different view so that I can see more of that anatomy.
Right.
And so patients are paying for exams. Those exams need to be diagnostic. You know, if you go and I'll just say, if you go buy a hamburger at McDonald's and that tomato's missing, you know, that's not going to affect your health, but they're going to be mad and they're going to be angry. So so patients need to be mad and angry that one, they might be misrepresented. They may have a misrepresentation of who is doing their images. Are those images quality so that they can be diagnosed? You know, and if they're misdiagnosed, that blame is going to go to the doctor, but if it was because of an image, that's on us. And then if it's because of limited scope or someone that was outside of their practice was doing those images, that goes right back on us too. Because if we didn't voice that opinion, and if we didn't voice and come together as a profession, then we have failed ourselves and those patients.
Right.
So what's your, like, it on the best day, this is how I would paint the picture. What is the best result for you, Jennifer? And what do you wish, how does affiliate membership help Tennessee?
So on the best day, I would be at a radiation imaging board with a full room of technologists and affiliate members speaking up and supporting licensure and what the members of that board are trying to do. That would be a perfect day to me. Or another perfect day is me to open up my email and I have 20 emails from different technologists asking for support of licensure. Or going onto social media and seeing multiple posts by people begging and urging those to revoke the bill that's being presented. You know, I think today that would be a perfect scenario. And then a year from now, I would love to go to an affiliate meeting and there be technologists sitting in those seats and having networking and talking about how their voices have been heard and being proud of that profession, and then patients recognizing that technologists are a profession and and that patients need to ask before they get their image if that technologist is licensed within the scope and that modality that they're performing.
Yeah, I wish we saw more advertisements from hospitals when they have staffed their radiology department with full ART certified technologists, like come to, Jones Memorial, because here we have, your patient care is our top priority. Your imaging is going to be met with the highest standard of care. Those are things that I think patients don't know that they should be concerned about until they hear them,
Right.
and we hear about it a lot in mammography, but it's so true for all other modalities. Why is it important that the person doing your MR is an MRSO or that they have their MR certification? It is important, and I wish hospitals bragged about that more. And I wish department managers supported their technologists attending affiliate meetings.
Well, I mean, can you really? I guess the first thing that you have to have is just support of your own technologist. If on Rad Tech Week, if your technologists don't get, if they don't get that appreciation on that one day, I think I've seen so many social media posts of, well, nursing got to have their week and they got to they had lunch every day and they got celebrated, and then today I came in and got a donut. And that's really on that imaging director's plate to, they're the ones that need to have a voice inside that hospital, for the technologist. But it's very unfortunate that, techs don't stand by each other and lift each other up. And it's unfortunate that patients don't understand, that there are different scopes of practices within medicine. And, and I don't know if a hospital even thinks that a patient thinks that's important. At Austin P, we do interdisciplinary simulations where we go into nursing, and their labs are amazing, by the way, but we go into their labs and we do communication labs. We teach them how important radiation safety is, why the image is the only reason why they're able to treat their patient, so that we have this mutual respect. However, when we get put on the news, because we have these interdisciplinary simulations, even the headline just says nurses. They know that that these are students learning radiologic technology, but I guess it's within the scope of a nurse. I'm not really sure why, the public, and the media doesn't want to educate to their listeners. What is the difference between a nurse and a doctor and a radiologic technologist? I mean, if they knew, then I think there might be more of an outcry, from patients to be able to be treated by the right person.
Yeah. I love that y'all do those collaborations. That's so important. We've been trying to do something like that at McNeese for a while now, and we just haven't really done it. So I love to hear that y'all are doing it. That's important.
They're so cool. It's just, you get to watch, you watch the technologist and the nurses communicating, and they're saying thank you to each other. They're asking for help, and you're just like, wow, this is amazing. But for nursing, there's certain standards that they have to follow. And so afterwards, they do this thing called a debrief. And the debrief has to be twice as long as the simulation. And the communication that happens between the professions, it's, for lack of a better word, it's just beautiful. Seeing that teamwork and that respect starting to build. It's really nice.
Yeah, I love that, especially considering most hospital administrators get their start in nursing. I think if we were incorporating those types of collaborations into all programs, we're at facilities that share both nursing and imaging, that's going to help everyone understand what imaging does.
We were looking at doing that at a different university, and we were talking to one of the nursing faculties, and she was just like, well, yeah, x-ray can transport the patient. I was like, no,
Yeah.
no, in a trauma situation we take x-rays.
Oh.
Like, no, we're not transport. They have transport. You know, you got EMTs and stuff that's bringing them in there. That's their role. We are not transporters.
I will tell you, if you want to develop a program, we have some amazing people at Austin P to hook you up with. We actually have a nationally certified simulation specialist in nursing that puts together our simulations. So we don't mind road trips.
Oh, that'd be great. That would be great. Well, there's one more point that I wanted to make kind of as we're closing out. And of course, I now don't remember what it was. But this has been a great conversation, I think.
Yeah. Thank you so much, Jennifer, for enlightening us, especially with the limited scope and knowing, you know, at first they were saying that they could take like certain body parts to images of certain body parts, but I didn't know they had to take a separate registry for each one.
Yep.
So I'm like, why wouldn't you just go on and take the full scope so you can get that over with? I mean,
well, I think it's because a person's in a doctor's office. They're working 9 to 5, Monday through Friday. The doctor's office doesn't want to pay for a full scope technologist. So they say, okay, I'm going to put you through school on the weekend. So when you get back, you can start doing these chest x-rays for me.
And why not abdomen though? I found that so strange. Like you can do a skull, but you can't touch an abdomen. What's happening?
You got the gonadal area there. So, I mean, that almost speaks for the profession that if a limited scope cannot image an abdomen, then they don't have the background knowledge to protect the patient. I mean, we can like put 2 and 2 together.
Right. But then, you know, like, I mean, even with urgent care clinics, every now and then, like my students like, oh my gosh, we have orbits, you know, who does orbits? But I mean, what if you get that? You're only doing chest. You're going to have to turn that patient around because you can't do orbits?
Yeah, so they'll have to put in an order to a hospital or another imaging facility.
So I think one of the biggest kind of changes that affiliates across the nation saw was the incorporation of social media and the internet and how that affected everyone's abilities to get CEs. So we can easily think about like, you know, the internet killed affiliates' purpose in some way because, you know, 30 years ago to get your CEs, you were having to go to these meetings. And because of that, managers supported your going to the meeting. Sometimes they even financed it. But the internet obviously has so many more benefits. You know, it has allowed us to get together today and have this conversation, whereas beforehand, you know, we couldn't have done it in this manner. It is so easy now to speak to our members and to our stakeholders, communities of interest. There's no reason that anybody in either Louisiana or Tennessee doesn't understand what's happening. So this is my plug for everybody that has a question after watching this video, or anybody who just feels motivated after watching the video, just to share it. Start conversations in your own departments of what it means to have limited licensure, how that affects patient care, how we can coexist. We can grandfather limited licensure in and move forward and still advance the profession. It doesn't mean we don't want limited licensure, you know, if they're already investing in patient care and performing exams. We don't want that to go away necessarily. We can incorporate it and happily coexist and move forward so that patients in the future are protected equitably all around. So I just encourage everybody just to continue the conversation. You know, become a member of your affiliate. Aside from your state licensure, be a member of your state affiliate. go to the affiliate meetings, pay attention to what's happening on their website and their Facebook page, you know, send some emails out, just have conversations with students and your other technologists in your department of what's happening and what it looks like and how we can all make a difference. And I really hope that the platform that Mr. Gonzalez is using at the national level helps the communities around us understand what it is that we do so that we can find our voice, because that's all that's lacking here is we just don't have a voice. And the three of us in a state, or the four of us, the handful of us in each state just aren't enough. We need more invested partners. That's my cry from Louisiana is I really just wish we had more people who understood the challenges and felt motivated to speak up, because it's not just MR, it's not just CT, you know, it's all of us together. And through social media, we have such a ability to make an impact. And here we sit, you know, with the same frustrations. I feel like every year it's the same thing. I wish there was an easier answer.
Yeah, I agree wholeheartedly. So even though it doesn't feel or seem like it's affecting us now, like in our different modalities, if it starts with one, it's going to trickle down to the other ones, because they see us as one. They don't see the differentiation between the different modalities. So again, we just have to rally together and be one voice, one big loud voice.
Well, Jennifer, you have advocates over here, you know, willing to stand behind you in Louisiana. So you let us know. We will rally the troops. We'll
Thank
come
you.
to your legislative meetings if we need to.
Right. Road trips.
You let us know.
Yes. Yes. Thank you so much. Thank you so much for giving me this platform to discuss what's happening in Tennessee. And I really, wholeheartedly hope that this is not a conversation that we'll ever have to have with Louisiana. But if it is, then we are learning from our situation, and we'll try and give you the tools to defeat any of these types of legislation that's going to go through that does not support our technologists and patient safety.
Right. Yeah, I agree. We can be mad all we want, but I mean, we got to put our words to action. You know, we can't just start saying stuff. So, yes, thank you so much, Jennifer. It was so nice to meet you.
You too. Thank you so much.
Yeah, Tennessee has a good thing in you. I hope they feel encouraged having you as president, because I can tell just in our hour here together that you are passionate about positive change. So
thank you.
all right, ladies, y'all have a good day.